Welcome to This Explainer, where we're going to cross-examine the evidence and filter the true signal from the noise in acute gastrointestinal emergencies. I want you to think of yourself not just as a clinician today, but as a clinical lawyer. You're presented with a complex, high-stakes case, and your job is to rigorously audit the facts, find the definitive proof, and make the final life-saving judgment. Picture this scenario. A patient rolls into the ER with severe right upper quadrant pain and a spiked fever. Do you call the surgeon right this second to make the cut, or do you hold off? You are the clinical lawyer on call, and to answer this life or death question, you absolutely have to find the exact physiological tipping point. If you misjudge the evidence here, the consequences are going to be catastrophic. To get there, here is our clinical framework. We're moving top-down today, starting with biliary speciation. Then, differentiating small bowel obstructions from paralytic ileus. Next, we'll discern the acute abdomen. And finally, we'll wrap up with some absolutely crucial executional pearls. All right, let's jump right into Module 1, biliary speciation, or what we call the obstruction hierarchy. The judge demands a strict audit of the anatomy here. You've got a 50-50 dilemma. Both acute cholecystitis and choledocholithiasis cause right upper quadrant pain, but the exact location of the stone changes everything. In acute cholecystitis, the stone is stuck in the cystic duct, so expect fever and an elevated white count, but completely normal bilirubin. However, in choledocholithiasis, that stone has dropped down into the common bile duct. The patient won't have a fever initially, but they will present with jaundice and elevated bilirubin. It's all about real estate. The anatomy dictates the labs. Ultrasound grounds our evidence, and it is your best initial test for a very good reason. When reviewing the scan, you are hunting for a specific triad. You'll see the gallstone, but more importantly, you want to identify a thickened gallbladder wall and surrounding pericholecystic fluid. When you spot those three things together, boom, your diagnosis of acute cholecystitis is completely locked in. Now, here is your absolute tipping point: jaundice. A cystic duct stone is simply not going to cause it. The exact moment your patient's eyes turn yellow and that total bilirubin spikes, you know the blockage is in the common bile duct. You're no longer dealing with a localized gallbladder issue, you've got a systemic biliary backup on your hands. But what happens if that blocked common bile duct gets infected? Well, now we've crossed into a massive medical emergency, ascending cholangitis. The infected system has nowhere to drain. It starts with Charcot's triad: fever, jaundice, and right upper quadrant pain. But if you don't decompress that system fast, it rapidly escalates to Reynolds pentad. Adding hypotension and altered mental status means they are crashing into life-threatening septic shock. To build a winning case, you've got to separate the pure signal from the noise. That sudden catch in their breath when you press deeply under the ribs, Murphy sign, is an incredibly high signal indicator for cholecystitis. On the flip side, if the ultrasound reveals a common bile duct dilated past 6 millimeters, you've just found your high signal proof for choledocholithiasis. Please, whatever you do, do not fall into this classic diagnostic trap. Ordering a HIDA scan for a patient who already has a clear stone and wall thickening visible on their first ultrasound is a total waste of precious time. Ultrasound is always first. You only bring in the HIDA scan if that initial ultrasound is completely equivocal. Moving right along to Module 2, small bowel obstruction versus paralytic ileus. This is our diagnostic dividing line. As we travel further down the GI tract, it's all about figuring out, is this a physical mechanical blockage, or is the bowel just functionally stunned? You have to interrogate those bowel sounds. High-pitched, tinkling sounds point straight to an SBO, because the gut is desperately trying to push against a physical barrier, usually adhesions or a hernia. But a completely silent, distended abdomen? That suggests a paralytic ileus, which is a functional failure often driven by bad electrolytes or a recent surgery. Your tipping point here, it's the transition point. With an ileus, everything is just diffusely dilated everywhere. But a mechanical SBO has a very clear anatomical landmark. You'll see dilated, air fluid-filled bowel proximally that suddenly and abruptly shifts to completely collapsed bowel distally. Finding that transition point is your smoking gun. When you're interviewing the patient, do not let frequent small stools trick you. That is just noise. It typically just represents overflow liquid squeezing past a partial obstruction. Your high signal warning that you are dealing with a complete SBO is true obstipation. Zero flatus, zero stool. And that brings us to a really critical error: waiting too long.
Initial management for an SBO is nasogastric decompression and fluids. But if you sit on a patient with fecal emesis for over 24 hours, you're literally risking a perforation. The definitive trigger is your physical exam. The exact second rebound tenderness or guarding shows up, conservative management time is over. They need to go straight to the OR for a laparotomy.
Okay, Module 3, the acute abdomen, appendicitis versus diverticulitis.
Now we're cross-examining the lower abdomen to sort out right-sided from left-sided inflammatory vectors. Age and the migratory pattern of the pain are your major tipping points here. Classic appendicitis usually strikes younger patients, with pain starting vaguely around the belly button before localizing sharply to the right lower quadrant at McBurney's point. Diverticulitis, on the other hand, is basically left-sided appendicitis. It typically hits older patients, presenting with distinct left lower quadrant pain and a noticeable change in their bowel habits.
Let's audit the physical exam. A positive psoas sign? That's a highly specific signal telling you the appendix is hiding retrocecally. But beware, if you suddenly find diffuse rebound tenderness across the entire abdomen, that is a massive, glaring red flag. It means the localized inflammation has burst, creating a dangerous peritonitic abdomen that needs immediate intervention. So picture an older patient presenting with that classic left lower quadrant pain and a fever. How you execute the workup is just as vital as the diagnosis itself. What imaging tests do you actually order? I cannot stress this enough. Never, ever order a colonoscopy or a barium enema during an acute diverticulitis attack. The bowel wall is severely compromised. If you introduce high pressure in there, you could literally blow a hole right through the inflamed bowel and cause a devastating perforation. Your correct, safe execution is a CT scan with IV contrast, period. Finally, Module 4, executional pearls, specifically the exact timing of the cholecystectomy. Let's close the execution gap on biliary interventions because this shows up all the time. You have got to memorize this timeline perfectly. For acute cholecystitis, the goal is an early cholecystectomy. For gallstone pancreatitis, wait for the lipase to drop and the inflammation to subside, sure, but you absolutely must operate during that same admission to prevent a fatal recurrence. And for ascending cholangitis, the definitive first step isn't even surgery. It's an ERCP to endoscopically decompress the tree.
And I really want to highlight this specific number, 72. You have a 72-hour maximum window from admission to execute an early cholecystectomy for acute cholecystitis. Hitting that window drastically cuts down both total hospital stays and major complication rates. In the totally unforgiving environment of the acute abdomen, misreading the evidence just isn't an option. Your ability to audit the imaging, interrogate the labs, and find that precise physiological tipping point is literally the only thing standing between a quick routine recovery and an absolute surgical disaster. So the next time you're on call and the pager goes off, ask yourself, have you truly separated the signal from the noise?